We are live.
Good evening, everyone, and a very warm welcome to iFocus Online Lecture number 501. Today's Ophthalmology Clinics exam special, we welcome Dr. Talvir Sidhu to discuss about approach to a long case glaucoma. She completed her... one second. She completed her MBBS and MS ophthalmology from AIMS New Delhi and her senior residency at the Glaucoma Unit RP Center, AIMS New Delhi. She's currently the Associate Professor at Government Medical College, Patiala. She's also the Associate Director for National Guidelines on Angle Closure Glaucoma and Primary Open Angle Glaucoma published by AIOS. She has also co-authored the book and published the video atlas on gonioscopy, a text and atlas. Over to you, ma'am. We're glad to have you here.
Thank you so much. So I'll share my screen. Is my screen visible, please?
Yes, ma'am.
All right. Thank you for this wonderful introduction, Dr. Ashwita. And I am going to talk on approach to a long case of glaucoma in your MD exam. So this is a case which I'm showing here. It's a 65-year-old female whose baseline intraocular pressure in the right eye was 24 and the left eye was 36. And right now she is on 3 medications and her average intraocular pressure is coming out to be around 14 to 16 in the right eye and 22 to 26 in the left eye. And her corneal thickness is 498. Dr. Ashwita or Dr. Megha, could you please tell me, looking at the gonio pictures and the disc photos, that what is the diagnosis of this patient?
Yes, ma'am. So it's a 65-year-old female with pressure high on both the sides, and all the 4 gonioscopy pictures look open. So probably an primary open angle glaucoma, and even the visual fields show advanced glaucoma visual field effects. An
Right.
advanced stage of primary open angle glaucoma.
Right. So, doctor, you have actually told me that this is a primary open angle glaucoma, but can you look at this picture? Can you see what is the configuration of the iris here? Is it a flat configuration or a convex configuration upwards?
Yeah, it's flat on one side, on the first 2 pages.
Convex on the other side. Yeah. So actually this is not an open angle. This is a closed angle where pigmentation is present anterior to the shawl base line. Here the angle is slightly opening, but on the other side you can see that the angle is not really opening up. It was actually a case of angle closure glaucoma. So this is what we are going to talk about today. And so when you work up a case of glaucoma, how do you work up any long case? Basically, when you go to an exam, your examiner won't straight away tell you that please tell me your diagnosis and let's discuss management and how will you do the surgery. No, you'll actually have to go through the history of the patient, the past history, presenting history, systemic, medical, surgical, personal history. Then you will come to think of some differential diagnosis. Then you will examine the patient. You'll do ocular as well as systemic examination. And then you will come to your most likely diagnosis, as well as you will come to your what are the DDs, other DDs that can be done. Once you have gone through the whole procedure, then probably if there is some time in the long case, your examiner will ask you what is the medical management that you will do or the surgical management that you're thinking of in this patient. So the first thing that we ask the patient is the demographic information. Name of the patient helps us in identification of the patient as well as familiarization. Age of the patient is important, especially in glaucoma. We all know that adult primary open angle and angle closure glaucomas, they present more than 40 years of age. Normal tension glaucoma slightly later in 50 years also. However, I have seen a few normal tension glaucomas who are around 45. Juvenile open-angle glaucomas at the age of 10 to 40 years. Congenital glaucomas are obviously younger, 0 to 10 years. Gender. When you talk about gender, angle closure is slightly more common in females. And when you talk about ethnicity, if you talk about the Western population, where majority of glaucoma is open angle, in India, you will find out that 1/3 to half of the patients have narrow angles and or have angle closure glaucoma. And open angle is slightly more common in urban than in rural population. When you come to the chief complaints, glaucoma is usually incidentally diagnosed. And when is it diagnosed? When patients come to you for either diminution of vision or for getting their cataract surgery done. However, there can be few complaints that a patient with glaucoma can present. It is advisable that you write them in chronological order. The first thing that the patient talks about is because of poor sensitivity, the patient might be needing more light to look at the objects. Second thing is, if there is advanced glaucoma, there can be a painless progressive diminution of vision with difficulty in seeing objects on one side or both sides, which can tell us that there is loss of peripheral vision. In angle closure, there might be dull ache, glare, and halos if there is corneal edema leading to halos around the light, and dull ache because of high IOP. Acute angle closure can actually present as a very painful red eye with a mid-dilated pupil. Raised IOP due to any cause. If it is a sudden raise in IOP, there can be dull ache in the eye or there can be severe pain also. In very advanced glaucomas, the patients can have trouble differentiating colors or boundaries of objects when there is very small tunnel vision that is present. Then coming to history of presenting illness, you have to ask not only the positive history, but also important that you ask the negative history from the patient. You have to ask the patient that when you got diagnosed with glaucoma the first time, what was your baseline intraocular pressure? Then you have to ask what are the medications the patient has used, systemic or topical, or any surgery the patient has undergone. What are the timing of medications that the patient uses, whether he uses any gap between those two medications, how does the patient instill the drops? Does the patient need a caregiver or can the patient actually, move around and put his drops on his own? In the negative history, it's important to rule out the use of steroids in any form, inhalational or ocular steroids or any oral steroids the patient might have taken. History of blunt trauma is important. Any history of other surgeries performed are also important. Coming to systemic history, it is important to know that there are certain diseases that increase the risk for open angle or other glaucomas. One is hypertension, diabetes, thyroid eye disease, Cushing syndrome. Vasospastic diseases like migraine and Raynaud's are associated with normal tension glaucomas also. Reduced ocular perfusion may be present because of systemic hypotension, because the patient is taking his hypertension medications at night, or due to ischemic heart disease, stroke, acute blood loss, carotid occlusive disease, or even obstructive sleep apnea. So all these things, they need to be elicited in a history for glaucoma. Then coming to the drug history, you have to ask whether the patient is taking systemic beta blockers, because in this case, topical beta blockers would work suboptimally. If the patient has taken corticosteroids in any form like eye drops, nasal spray, inhalational, or even oral, there are drugs that can precipitate angle closure like anticholinergic drugs used in asthma like ipratropium, tiotropium, Parkinson's disease, and in incontinence like oxybutynin. Cimetidine and ranitidine can also precipitate angle closure. SSRIs, anti-allergy drugs like diphenhydramine, sulfonamide medications like topiramate, tetracyclines, they can cause ciliary effusion and precipitate angle closure. Ocular perfusion can decrease in patients who are taking hypertensive medications at night. So these are important histories that need to be elicited. Family history of glaucoma is very important because it makes a person at a very high risk for glaucoma if they have first or second degree relative who has glaucoma. If the family history is positive, you must make a family tree and denote which of the relatives of the patient are positive. Then personal and occupational history are also important. You should know whether the patient can drive, whether the patient does any exercises which involve yogic postures, which are causing Valsalva maneuver, which can raise or decrease the IOP very suddenly. whether the patient takes 1 liter of water in the morning after he gets up. Because if you take 1 liter of water in the morning, it can actually lead to a rise of IOP in the morning. Smoking, alcohol, wearing a very tight necktie, then excessive weightlifting, trumpet blowing, or scuba diving. All these things that you should ask the patient whether he's doing or not. Now coming to the examination. After a very detailed history, you need to look at the patient's, first of all, systemic examination, extraocular, and ocular examination. General systemic examination of the patient must be done, even if it is done or done for a very, you should check the pulse and the respiratory rate of the patient. If there is irregular heart rate, you should always mention it. Sometimes you might miss, anybody might miss any systemic illness which might be lingering on in the patient, and it needs treatment. Now coming to extraocular examination, it is important that you look at the face of the patient. You look whether there are any hemangiomas that are present on the face. Like here in Sturge-Weber syndrome, there is a hemangioma which is present on both the eyelids. This can cause congenital glaucoma as well as later on acquired glaucoma because of raised episcleral venous pressure. Here you can see this lady, she has a nevus on her cheek as well as there is pigmentation on the sclera and the iris is very dark. This is ocular melanosis, which can lead to actually your pigmentary glaucoma. Exophthalmos itself has been associated with raised episcleral venous pressure, raised intraocular pressure, and glaucoma. Now coming to visual acuity and refraction. So it is always important to know that you are not presenting a case of glaucoma. You are presenting a case in ophthalmology. So when you are doing visual acuity, you should do uncorrected visual acuity for distance and near. And after doing retinoscopy, in children, it can be done under cycloplegia. And in adults, it can be done under tropicamide itself. Retinoscopy, after giving retinoscopy, you should give power of glasses and you should give a near ad in adults who need it. You should also mention the type of refractive error the patient has, whether it is a simple refractive error, compound or mixed, type of astigmatism, regular, irregular, with the rule, against the rule astigmatism. It is obviously important that you mention which charts you have used to check the visual acuity. You should check projection of rays in all patients of glaucoma, because in patients who have very advanced glaucomas, even with very good vision, in dark room, the projection of rays might not be accurate. Then in angle closure glaucoma, usually they can be hyperopic. If you cannot dilate them, use a fogging method to overcome the excessive accommodation that they might have. Then we have open angle glaucomas. They usually myopic. And then coming down to pupillary reactions. It is important that you do this in dark room and you check direct and consensual reaction. This is a video which is showing swinging torchlight test, and there is a RAPD in the left eye of the patient. Now coming to the eyelids. You must check the eyelids for any infections or any other things like long eyelashes. Long eyelashes are usually associated with advanced use, with a very long-term use of prostaglandins. Along with long eyelashes, the patients might have tight lids, upper lid ptosis. Then the patient might have deepening of the upper lid sulcus and mild enophthalmos as seen in the second picture. This is called prostaglandin-induced periorbitopathy. Then patients might present to you with allergic blepharoconjunctivitis also due to certain drugs. When you look at the conjunctiva, ciliary congestion might be present in acute angle closure glaucoma. You can see this picture. There's a fixed dilated pupil with a shallow AC and a vertically oval pupil. This is a acute congestive glaucoma in a patient. And the upper picture, you can see that this patient has redness in the lower fornix, whereas upper conjunctiva seems to be unbothered. It's a white conjunctiva. So this is conjunctivitis medicamentosa, which means the eye drops that he has been putting into his lower lids have caused allergy. In conjunctiva, you must look for a bleb. If the trabeculectomy surgery has been done, you have to do bleb grading. So Indiana bleb grading scale is usually used. When you look at the height of the bleb, it ranges from H0 to H3. So H0 is that there is a flat bleb. If there is low elevation, it is H1. There is moderate bleb elevation, it is H2. If it is a high bleb elevation, it is a H3. Then coming to extent. Extent is actually the horizontal extent, the black arrows that you're seeing. If it is a less than 1 clock hour extent, it is E0. E1 is 1 to 2 clock hours. E2 is 2 to 4 clock hours, and E3 is more than 4 clock hours, means it is a large bleb. Then you look at the vascularity. V0 is avascular and white bleb. V1 is avascular cystic bleb. V2 is mild vascularity. So this is an ideal bleb, V2. V3 is moderate vascularity and V4 is extensive vascularity. Positive Siedel's tests must be checked on the slit lamp using fluorescein dye. So here you can see that there is a leak from the bleb area. So if there is a positive Siedel's test, it should be mentioned. Then coming at the scleral examination, in the sclera, thinning of the sclera or staphylomas might present in painful blind eyes which have glaucoma. So there can be anterior staphyloma as seen in this picture. There can be intercalary staphyloma as seen here. There can be, ciliary staphyloma as seen here. These are intercalary staphylomas. There can be mix of multiple staphylomas also because of in a chronic painful blind eye. And here you can see, this is a picture where you can see a episcleral hemangioma, which is causing glaucoma in this eye. Here you can see dilated episcleral veins due to corticocavernous fistula, which can also cause a secondary rise of IOP. Here you can see ocular melanosis with a very dark colored iris. Actually, the other eye usually has a lighter colored iris, and there can be malignant. There can be pigmentary glaucomas in these eyes. Now looking at corneas. In the cornea, you have to measure the CCT. So first thing is that you should know that thin cornea is a risk factor for glaucoma. Any cornea which is thinner than 500, you should think of it as a thin cornea. And also you should use Ehler's formula, that is subtraction of 0.7 millimeter of mercury for every 10 micrometer difference from 520 for your applanation tonometry. Average CCT in Indians is around 514. Also, other abnormalities in the cornea. Here you can see in this picture that there is a ground glass haze in the cornea due to corneal edema in an acute angle closure glaucoma. Here you can see that there is a pigmentation which is present. It's a diffuse central vertical pigmentation, which is a Krukenberg spindle in a pigmentary glaucoma. Here you can see two horizontal parallel tears in the descemet's, which is Harb stria. Here you can see a posterior embryotoxin. So you should look at the cornea and endothelium very carefully to look at any abnormalities that can be present. Also, never miss KPs on the endothelium because uveitic glaucomas are not very uncommon. Also, when you have looked at the cornea, please draw the corneal diagrams. If there is a Harb stria, make the Harb stria. If there is edema, draw the corneal edema. And you should always represent your findings in a drawing. Then usually the examiners would ask you what is a Fincham's test. Fincham's test is when you take a stenopic slit and it is passed in front of the eyes. Intact halos, they indicate acute glaucoma, and broken halos, they indicate a cataract. Now coming to the anterior chamber examination. Anterior chamber examination should be done first with torchlight. If you can see that the iris is lying flat with a torchlight, usually these people have a deep anterior chamber, and in an eclipse sign, you know that it is a shallow anterior chamber. And Van Herrick grading is done at the outermost part of the cornea, where a thin slit is actually projected onto the cornea at an angle of 60 degrees, and you see what is the depth of the anterior chamber just inside the limbus. So Van Herrick grading can be done as grade 0, where there is no black space. In grade 1, there is less than 1/4 of the cornea black space. And then we have grade 2, the space between the cornea and the endothelium and the iris is actually 1/4 of the thickness of the cornea. Then here it is half, and in grade 4, it is 1 or more than 1. Shallow AC is usually present in angle closure glaucoma, angle closure or primary angle closure suspect. Sometimes pseudo exfoliation also, it can present with shallow anterior chambers. Deep anterior chamber is present in open angles, in trauma, in juvenile open angle glaucoma, in congenital glaucoma, pigment dispersion syndrome, and pseudo exfoliation can be present in either open or closed angles. So now coming to the pupil. When you talk about the pupil, you talk about the shape, the size, the rough, and the abnormalities. So first of all, the shape. Pupil is usually central and circular. Vertically oval pupil is usually seen in angle closure glaucomas. Myotic pupil is usually seen in uveitis and fixed dilated in angle closure. Rough is usually absent in angle closure. Ectropion UVA can be present in congenital ectropion UVA or in neovascular glaucoma. So abnormalities, there are various abnormalities as we can see here. This is a central circular pupil with a very good intact pupillary rough. Here you can see that the pupillary rough is very well maintained in the upper and the lower halves. On the sides, the pupillary rough has become a bit atrophic and it is a vertically dilated pupil in case of angle closure glaucoma. Here you can see that there is traumatic iridodylisis and which is causing a D-shaped pupil. Here there is a fixed dilated pupil because of trauma. There are breaks in the rough. You can see that there has been trauma to the central pupil and the constrictor muscle. So here you can see that there is polychoria. In polychoria, the original pupil is lined by the rough. That is what you should remember. So this is the original pupil which is lined by the rough, which will react to light. Here you can see that there is correctopia. Pupil has shifted to one side. Here you can see that there is neovascularization at the iris. And this is usually seen as very small red vessels around the pupil. Here you can see pseudo-exfoliative material on the pupil. This is ectropion UVA. Then you talk about the iris. You talk about the color of the iris, whether the pattern is maintained or not. And then you talk about the abnormalities of the iris. So the color of the iris can be brown, light, or it can be very dark. Then we have pattern. Pattern can either be present or lost. Featureless iris can also be seen. Transillumination defects can also be seen. This is a very important and a beautiful slide which shows you what happens in angle closure. What happens in angle closure is that there are very high IOPs which cause the ischemia of the pupillary border and the constrictor pupillae muscle. So here you can see that the rough is intact over here and the pupillary rough is lost on this side. Similarly, here you can see that the pupillary rough is actually intact here and it is lost on the other side. The constrictor pupillae muscle has constricted here like a rubber band, causing a whirling of the iris. Here also you can see the whirling of iris on top and lower part and atrophy of the iris on the other sides. This is also another part where the atrophy of the iris has occurred because of ischemia of the iris. This is a fixed dilated pupil that has happened in angle closure. Here you can see over the lens, there are whitish opacities as if milk has spilled. This is called milk spilt appearance or glaucoma flecken. Now looking at iris, trans-illumination defects on the iris on retro-illumination can be seen in pigment dispersion. This is absence of iris, that is aniridia. Here you can see that there are atrophic patches over the iris and these patches have occurred due to essential iris atrophy in ICE syndrome. Here you can see there are golden nodules over the iris in neurofibromatosis. These are leash nodules that are usually bilateral. Here you can see that there is melanosis over the sclera and the iris is very, very dark with iris mammillations. This is ocular melanosis. Here you can see Cope's nodules and Busaka's nodules, these and a cataract in the center. This is Fuchs heterochromic iridocyclitis. Now talking about the lens. When you talk about the lens, you talk about transparency, the position, the capsule. You talk about whether the lens is thick or not. So transparency grading is done according to the cataract workup. Otherwise, here in the pictures, you can see that there is pseudo-exfoliative material over the lens, which is seen in a target sign in the over the lens capsule. Here you can see a rosette cataract because of trauma. Here you can see in the third picture that there is a intumescent cataract with a very shallow anterior chamber leading to angle closure glaucoma, which is lens induced. And here you can see milk spilt appearance, which is glaucoma flecken. Also, it is important that you check the sensations of the check the sensations of the cornea when you're doing an examination, because there can be, because of very high IOP, there can be loss of sensations also. Your cornea, iris, and lens, they should be shown in a biomicroscopic findings as a drawing like this diagram has been shown. Now coming to tonometry. So before doing your gonioscopy, you have to do your tonometry. Gold standard is GAT. I think we all know how to perform GAT. I want to tell you that you should at least take 2 to 3 readings, and you should avoid pressing the globe. Also, after you clean your prism, you should wait for at least 1 minute so that you do not cause an epithelial defect, because that shows very poorly if you've caused an epithelial defect just doing a tonometry. So now coming to gonioscopy. Gonioscopy, which type of lens should you use? During your exam, it is better that you use a 2-mirror lens, because it will be easy for you to use and it will give you very accurate findings, and you can do manipulation gonioscopy. Gonioscopy should be done in a dimly lit room, and the gonioscope should be pressed, or not pressed over the cornea, but gently placed, and a thin beam should only go to the angle. Once you place a thin beam in the angle, you will see a corneal wedge. If you see a corneal wedge, that indicates the position of the shawl base line. Behind the shawl base line is actually your angle structures that are present. If you see a straight line behind your corneal wedge, that is your angle structures. That means that this angle is likely to be open. So this is your corneal wedge, and this is the straight line which indicates an open angle. Now, the angle structures that you should see is ciliary body band. The white line ahead of the ciliary body band is the scleral spur. Then we have the trabecular meshwork, and then we have the shawl base line. Your corneal wedge should be formed at the level of the shawl base line. In a closed angle, you will see that the iris is actually convex and your corneal wedge is forming, but there is no straight line behind it. All right. So this shows, because there is no straight line behind it, the angle is actually covered by the iris. That means it is closed. So then you mention the iris configuration. Iris configuration is the line of light that is present over the iris. So here you can see that there is corneal wedge formation. There is a straight line behind it, and the iris is actually lying flat. So this is a regular iris configuration. Convex iris configuration is when the line over the iris is actually bowing anteriorly. This is in angle closure. And then we have concave iris configuration. Here the iris is actually bowing posteriorly, causing this pigment to release in pigment dispersion syndrome. This is a concave iris configuration. So then we have levels of iris insertion. If you see in the picture F, the iris is actually inserted onto the ciliary body. You can see the ciliary body band. Sometimes the iris is inserted directly behind the behind your scleral spur. So this is also normal. But in juvenile angle closure or juvenile open angle glaucomas or congenital glaucomas, you might see that the iris is actually coming over the trabecular meshwork. So you can see in picture C as well as B that the trabecular meshwork, the iris is inserting onto the trabecular meshwork. However, the iris is still lying flat. It is not an angle closure patient. And here also you can see there is hardly any trabecular meshwork, but the iris has not even iris is inserting over the trabecular meshwork right near the shawl base line. So then talking about the grade of pigments, trabecular pigment is also graded from 0 to 4. Grade 4 is excessive pigmentation, which is present in pigment dispersion. Grade 3 pigment can be seen in normal angles also. Grade 2, grade 1 and grade 0 are less pigmentation. So the pigmentation of grade 3 is actually equal to that of the color of the iris. Here you can see in grade 4, the pigment is darker than the color of the iris. That means a lot of pigment has released into the angle because of pigmentary glaucoma. So now gonioscopy in open versus closed, as I've already talked about, here you can see that the angle structures are not really discernible, but when you make a corneal wedge, you can see a straight line behind the shawl base line. That means the angle is open and also the iris is lying flat. Here you can see some pigments that are present, as I had shown in the case with that you had seen first. So here you can see that there are pigments which are lying somewhere in the angle. We don't know what it is, whether it is trabecular meshwork or not. But when we are making the corneal wedge, this is actually the level of the shawl base line. and you cannot see any straight line behind it, which means the angle structures are actually closed. So that is the importance of making a corneal wedge and knowing. So this is an angle closure person. So when you do a manipulation gonioscopy, in the primary gaze here, in the primary gaze, no angle structures are seen. But when the patient looks up, all the angle structures are seen. Here you can see that there is some pigmentation present in the angle. So this is blotchy pigment that is present in the angle. Here you can see when we do manipulation, there are multiple goniosynechiae that are present, which are hill valley appearance. And here when the patient is trying to look up, you will see that nothing opens up. Only the shawl base line is seen. This is the picture of gonioscopy which I had put in the first case. So this is complete angle closure. This is some angle closure where goniosynechiae are present. And here you can see some blotchy pigments. And here the angle is still opening up. So this is primary angle closure suspect. This is primary angle closure where goniosynechia have started and you need to do a YAG PI. And here it is primary angle closure glaucoma where angle has already closed and it is not even opening up on manipulation. Indentation gonioscopy, usually in exam it is not done, but indentation gonioscopy helps you identify the difference between synechial versus appositional angle closure. Secondary open angle glaucomas are pseudo exfoliation. Here you can see pseudo exfoliative material in the angle. Dr. Megha, could you please tell me what is this picture?
This is an hyperpigmented posterior trabecular meshwork. So probably either because of trauma or because of pigment dispersion syndrome.
Thank you so much. So this is, you can see that the pigmentation is very dense and the pigmentation is very uniform. So this is a pigment dispersion syndrome. And here, what can you see in the lower picture?
We see a sudden widening of the band. So this could possibly be post-traumatic angle recession.
Very good. So secondary open angle glaucomas can be many. It can be uveitic, it can be pseudo exfoliation, it can be pigmentary glaucomas. So all these things need to be kept in mind. That is why your gonioscopy aids in the diagnosis of your glaucoma. So secondary angle closure can be due to neovascularization. Here you can see multiple vessels in the angle and the iris is being pulled onto the trabecular meshwork. Here you can see uveitic angle closure where broad-based goniosynechia are present. Here you can see that there are small tree-like stubs on the iris and there is a lot of angle closure that is happening. This is eye syndrome version. The variety is Cogan-Rees syndrome. And this is a secondary angle closure because the IOL has actually been captured and there is a secondary angle closure. There is no PI. So the entire iris has come ahead. It is always important that you make a goniogram to show whether the angle is open or closed, where are the abnormalities that are present in the angle. You should mention iris configuration, pigmentation, angle recess. You should always mention the level of iris insertion and findings of your manipulation. If the findings of manipulation can be shown in a cross form, this is where the from primary gaze anterior trabecular meshwork was seen, but when you manipulated the posterior trabecular meshwork or the scleral spur is seen. So these things should be mentioned. Now coming to the optic nerve head changes. So optic nerve head changes, it is important that you must dilate a patient. If the patient has angle closure, you must check whether the PI is patent. If the PI is patent, you should dilate the patient. It is also important to note the size of the optic disc, the shape of the optic disc, and then comment on the other things. The examination can be done with a 90D or a 78D lens. You can measure the size of the optic disc on the graticule of the slit lamp. Small size discs are less than 1.5 millimeter and larger ones are more than 2 millimeter. And you must check the lens and the correction factor that you're using. For a 66D, there is no correction factor. For a 90D, there is a 1.33 correction factor. Also, you can check the size of the disc with the help of the Welsh Allen 5 degrees medium size spot. The small disc falls within the spot and the large disc falls outside of the spot. In people who have hyperopia, they usually have small discs. In people who have very high myopia, they usually have a very large or elongated disc. And why is that important? It is important that when you check the cup disc ratio of the patient, you have to see whether the disc is small or large. In a normal disc, it follows the neuroretinal rim of the patient. It follows a isn't rule. It is important to write this in the paper. Also, it is important to write whether the inferior rim is thicker than the superior, than the nasal and the temporal. Like here, it is a normal optic disc and it follows a isn't rule. Here you can see that it is a glaucomatous disc and the inferior rim is thinner than the nasal rim. Even the superior rim is thinner than the nasal rim. So the isn't rule is followed or not, you must write that. You should always check for contour cup versus color cup. So here when you look at the central cup, you think that the cup is only this much. But when you look at the neuroretinal rim and the contour, you see that the neuroretinal rim from outside, it ends over here. From here, it ends almost over here. So compared to the color cup, the contour cup can be usually bigger. Now coming to typical optic nerve head changes in glaucoma. The typical optic nerve head changes in glaucoma are shown in this picture. You can see that there is an inferior neuroretinal rim notch that is present. You can see a superior RNFL defect and inferior large RNFL defect. You can see bearing of circumlinear vessels. You can see that there is enlargement of the vertical cup disc ratio. Also, there is nasalization of the major vessels that can be seen. This is called overpass cupping. It seems like this vessel is actually hanging on inside of the cup. And also there is some alpha peripapillary atrophy that is present. This is a disc hemorrhage associated with the RNFL defect, which can be seen in normal tension glaucomas. In high myopes, there can be saucerization of the cup like this. It can look like a shallow saucer. In juvenile open-angle glaucomas or congenital glaucomas, there can be a concentric cupping of the optic disc rather than a notch. RNFL defects can be seen on red-free better than the colored photographs. Here you can see a RNFL defect which is better observed on a red-free filter. So these are usually wedge-shaped defects which start at the disc and are narrow at the disc and they go up to the horizontal raphe. Some examiners might ask you the disc damage likelihood scale. What you should remember about this is you don't have to learn it. DDLS is divided into 10 stages depending upon the size of the disc as well as the neuroretinal rim loss. What is the importance of disc damage likelihood scale is that it makes sure that the examiner examines the optic nerve size and the rim rather than just the cup disc ratio when looking at the optic disc. It is important that you make a disc diagram. For example, here in this disc, there is a superior and inferior notch that I have made. Peripapillary atrophy has been shown. Bearing of circumlinear vessel has been shown. Cup disc ratio has been mentioned and RNFL defects have been mentioned. Now, it is also important that after you have done this, you examine the entire retina and you make the retina chart and you also fill in all the other findings that you usually see in an ophthalmic case. Please do not skip those. Now, important thing is to note and know what are the DDs of enlarged cup disc ratio. Enlarged cup disc ratio can be physiological cupping where isn't rule is followed in a very large disc. So this is a 0.5 to 6 cupping in a large disc. Here, this is a glaucomatous cupping where neuroretinal rim is absent. Here you can see there is a pale disc. There is a bow tie shaped pallor. You can see temporal as well as nasal pallor. Nasal and the whole disc is pale. There is enlarged vertical cup disc ratio in optic atrophy. Here there is a pituitary tumor and bitemporal hemianopia because of the same. You can see that this is a very large disc. Optic disc coloboma is present here and that is actually causing an enlarged cup disc ratio. Here you can see there is a optic disc pit that is present in an unusual position, which is causing enlarged cup disc ratio. Now coming to DDs of disc hemorrhages. Sometimes hemorrhage at the disc can be caused due to vitreopapillary traction, that is PVD. And in undiagnosed diabetes or in hypertension also sometimes it can happen. optic neuropathy or in optic disc drusen, there can be disc hemorrhages that can be present. So these are important questions that your examiner might ask you, and how to differentiate these from glaucoma, you should know. Now coming to visual field defects in glaucoma. Visual field defects in glaucoma usually occur at the germs area. They usually correlate with the abnormalities that are seen on the optic nerve head, usually respect the horizontal midline. Here you can see that the defect starts from the optic disc and it goes up to the horizontal midline. Also, the optic disc is usually not included in the central 10 degrees. It is usually included in the 30 degrees. Glaucomatous neuroretinal rim defect, it actually causes a visual field defect. That is why if you have a small notch inferiorly, there will be a superior arcuate scotoma. If there is notch in the superior and the inferior part both, you will have a biarcuate. If you have advanced rim loss, then you will have a central tunnel vision that is present. So you should always clinically correlate your visual field with your optic disc. Also, you should know the Hoda-Parrish-Anderson criteria, that how do you actually define a scotoma in a visual field. Now, it is important that your examiners might ask you, what are the visual field defects due to other diseases which are similar to arcuate scotomas? So, retinal vein occlusion, especially BRVOs, can lead to arcuate-like scotomas. Then we can have isolated colobomas, which can lead to paracentral scotomas. Even NAION, it can lead to inferior altitudinal defects. Myelinated nerve fibers can also lead to the defect of the visual fields. Optic disc hypoplasia, you can see here on this side, there is optic disc hypoplasia leading to the visual fields. Then visual fields that are leading to tunnel vision. So here you can see retinitis pigmentosa is one disease which can lead to tunnel vision. Extensive PRP, if it is done, that can also lead to tunnel vision. Central retinal artery occlusion can also lead to tunnel vision, especially if there is sparing of the ciliaretinal artery. If there is bilateral occipital infarct, that can also lead to bilateral tunnel vision. Now, when you come to the diagnosis and differentials, so we have talked about intraocular pressure, we have talked about optic disc, gonioscopy, all the examination that is possible on the iris anterior chamber, and then we have to do a 1+1 to get to our diagnosis. So, talking about primary open angle glaucoma. Dr. Megha, has it been clear up to this mark for you, please?
Yes, ma'am. Very much.
Oh, thank you so much. So, going back to what do you expect in a primary open angle glaucoma? Will there be optic disc changes in primary open angle glaucoma? Will there be a notching and everything?
Yes, ma'am.
Yes. So there will be a optic disc notch which will correspond with the visual field defect. The baseline IOP in primary open angle glaucoma is usually 21 to 35. And on the angle examination, you will see that the anterior chamber angle is gonioscopically open. And the age of the patient is usually more than 40 years, right? So now, when you talk about normal tension glaucoma, it will have optic disc findings, visual field corroborating. It can have extra disc hemorrhages, right? The intraocular pressure is usually in the normal range. That's very important. And the age of the patient is usually older than open angle glaucomas. Now, the difference between primary open angle glaucoma and juvenile open angle glaucoma is not just the age of the patient. The age of the patient is usually younger. Also, the angle, there can be anterior insertion of the iris. The baseline intraocular pressure is much higher than that of the primary open angle glaucoma. Juvenile open angle glaucoma can also have, instead of notching, can have concentric cupping. So you have to do a 1+1 to get to your diagnosis. And congenital glaucoma cases are not usually given to, as exam cases, but still they are obviously younger and the baseline IOPs are much higher. There is concentric cupping, which is reversible when you reduce the intraocular pressure. Now coming to angle closure. So there are three terms that you need to be aware of, because in a patient who is coming to you with angle closure glaucoma, it is not necessary that both the eyes have angle closure glaucoma. One eye can have primary angle closure glaucoma and the other might be primary angle closure. So first of all, let's talk about angle closure suspect. Angle closure suspect is a person who has trabecular meshwork not visualized in 180 of the angle. There are no gonioscopy, no goniosynicae, no blotchy pigments in the angle. So these are the people who have an occludable angle, but they have not progressed to goniosynicae formation. The intraocular pressure is normal, visual fields are normal, and optic disc is also normal, right? So here you do not need to do a YAG PI. In primary angle closure, what happens is that it has advanced to occludable angle, that is trabecular meshwork not visualized in 180 of the angle, and it has goniosynicae or blotchy pigments. Now, because there is angle damage that has started occurring, there can be a high intraocular pressure. But optic disc and visual fields are still normal. So here you need to do a YAG PI so that it does not advance into angle closure glaucoma. But you still need to monitor them because a damaged angle might have high IOP later on also, which can progress to angle closure glaucoma even despite the YAG PI. Now in angle closure glaucoma, there is occludable angle, there are goniosinicae. The baseline IOP is usually higher than open angle. It can be 21 to 50. The visual fields are usually corresponding with the optic disc. However, it is important to know that angle closure, juvenile open angle glaucomas, even pseudo exfoliation glaucoma, because they present with higher baseline IOPs, they need to be aggressively controlled as compared to open angle glaucomas. If the baseline IOP patient is presenting to you with a very high IOP, you might need to start them off with oral anti-glaucoma like Dimox. So these are very important. Now coming to other terms like ocular hypertension. Ocular hypertension, it means that the angle is open, the visual fields and optic disc are normal. However, the intraocular pressure is higher than normal on multiple occasions. These people, they need to be monitored and not started treatment immediately. Then we have glaucoma suspects who have a suspicious disc, which means cup disc ratio is more than 0.6. However, visual fields are normal, baseline IOP is also normal, and angle is open. Then we have secondary glaucomas. Now, secondary glaucomas have other pathology in gonioscopy. So the gonioscopy is very important to diagnose your glaucoma. So now I've started with the cases. Dr. Megha and Dr. Ashwita, would you please like to, talk about these? So the case one is a 61-year-old male who has presented to us for routine eye examination. The mother has glaucoma. The patient is asthmatic on inhalational steroids. Baseline IOP is 28 and 34. And the gonioscopy picture is this. You can see that there is a ciliary body band. You can see the scleral spur and the trabecular meshwork and normal pigmentation, not much pigmentation. Could you please comment on the optic disc of both the sides and visual fields?
Ma'am, the right side optic disc, it seems to have there's peripapillary atrophy in on both the sides. On the right side, there is a slight nasalization of vessels,
Right.
and there is thinning of the neuroretinal rim more on the left than on the right.
And visual fields?
Uh, there's a peripheral defect on the right side, and for the left eye, there is an arcuate defect, which is respecting the horizontal median.
Right. So what we
In the
have
Jerem's
talked
area.
about is, yeah. So what would you say the diagnosis of this patient is? So we have a 61, the age is 61. We have higher baseline IOPs. The patient has open angles and there is definitive glaucoma on optic disc and visual fields. So what is the diagnosis, ma'am?
This could be primary open angle.
Yes. So this is primary open angle glaucoma, right? And how do you stage this disease? is it early disease, moderate disease, or advanced? Right eye is definitely very early, right?
Yeah,
Because
it's been.
there is, yeah, it is hardly any, points that it probably, if we repeat the visual field, these points might also come to normal. And in the left eye, you can see one half of the visual field is involved. It is either moderate going into advanced in the left eye, right? So this is early, or you can say left eye is moderate to advanced. So this is an open angle glaucoma. So now the risk factors are that the mother has glaucoma and he's also asthmatic. And now we can see that on medication, his IOPs are 18 and 20. So
Mm-hmm.
is it okay to keep 20 intraocular pressure in his left eye where he already has a arcuate scotoma? What should we keep the IOP like?
In the range of 12 to 15, ma'am.
Because there is moderate to advanced
Yeah.
glaucoma, yes, it should be less than 15, right? And in the right eye, however, we can keep it to 18 and 16. So we might need to change or increase the medications of the left eye, and the right eye, we can keep it the same. Thank you. So this is the second case. So in the second case, Dr. Ashwita, would you like to comment, please? This is a 35-year-old male who has come to you for routine eye examination, and the pressures of this person is 28 and 24, and we have gotten a diurnal variation done. So the highest pressures are actually in the morning, that is 28 and 24. And also in the optic disc, what can you see, ma'am, in the optic disc?
This is a right optic disc, so there's temporal thinning and inferior rim thinning. The nasal and the superior margins look healthy, the healthy neuroretinal rim.
Right.
There is no nasalization or bionetting sign, so it could be early changes of
You can see this RNFL defect here,
RNFL defect.
and there is a thinning here that is present, and RNFL defect also that is present. But here there is hardly any RNFL defect or thinning. Isn't rule is being followed, right? What do you see in the gonioscopy?
We can see up till the ciliary body band, and all the ciliary body band appears thickened. But
No, actually this is your pigment dispersion that is happening. So this is a 35-year-old male. There is a very dark band of pigment present ahead of the scleral spur. So this is the iris and the scleral spur. Then we have a very dark pigment, and this is a Shaw-Bayes line here. So this is a very uniform, pigment which is in pigment dispersion syndrome. So this person has pigment dispersion syndrome, and the staging actually it is early glaucoma in the right eye only. So do we need to treat this person?
yeah, since the pressures are high, the baseline IOP is high, with the highest being 28 and the lowest being 18. I think we
Yes, we
should
do need to
call
treat this
them.
person.
Yeah.
Very, very good. Yeah, we need to treat this person. This is the same case that we had seen earlier. So this lady, she has actually, when she's looking up on manipulation, also hardly any angle opening is happening. Here, some angle opening is happening. This is a person who is 65-year-old female with angle closure glaucoma, and the stage is advanced in both the eyes. However, when you look at her central corneal thickness, it is thinner. So it is a risk factor for progression of glaucoma. Second thing is that on treatment with three drugs also, her IOPs in the left eye are much higher than what they need to be, even after doing a PI. So we might need to think of what in the left eye? A trabeculectomy we might need to think of. So this is how you need to plan your cases. So this is another case. Could you, Dr. Megha, could you quickly tell me what is happening to the optic nerves here? Is there more cupping or more pallor?
More pallor than cupping, actually.
Very good. So this is an open angle. This 48-year-old male actually came to us. These are true cases. So this person came to us. He had open angle. He was on one drop latinoprost, but optic discs were slightly pale. The IOPs were normal. And when we did a visual field, what kind of a visual field is this, please?
These are neurological fields, because
You can see that the optic disc is involved in both the sides. So this is a bitemporal hemianopia almost, right? And we did a MRI of the patient, and we found pituitary tumor, right?
yeah.
I think during my senior residency itself, we diagnosed 3 or 4 patients like this. So this is very important that you look at whether there is more pallor or more cupping. So now what is the time, Dr. Megha, could you please tell me?
We have another 5 minutes, ma'am.
We do have, right? So when you talk about if you have come to this point in your MD exam, so now your examiner will ask you what are your goals of treatment. So first thing is to achieve target IOP, lessen the side effects of the medications, make it affordable and stop the disease progression. The principles of management is first establish the diagnosis. We need to know whether the patient had higher baseline IOPs. We need to know whether the patient has any accessory risk factors so that we need to keep the target IOP lower or not. Then we will initiate the treatment and look for progression. So target IOP obviously depends on the optic nerve head, the life expectancy of the patient, rate of progression, the fellow eye status. If the patient is one-eyed, if the patient is young, if the patient has excessive nerve damage, has many systemic diseases or excessive risk factors, then we need to keep the target IOP lower. To make it very simple, the target IOP actually can be in early glaucoma. We can keep the target IOP from 16 to 18. In moderate glaucoma, we can keep the target IOP from 14 to 16. And in advanced POAG, we can keep it less than 12. And when you talk about medications, the first thing that you need to do is do a YAG-PI in angle closure, even if you have to give Dimox. Then coming to medications, we have various medications like prostaglandin analogs, beta blockers. We have your carbonic anhydrase inhibitors and alpha blockers. So the first line is prostaglandin analogs. If the patient is tolerating the drug better and has reached the target IOP, then we can keep the patient on that drug and periodically follow. If target IOP is not reached beyond 2 drugs, then we really need to make sure that you have to add laser therapy or surgery to reach the target IOP. The whole and soul of the glaucoma management is that the patient should not progress from when he has been diagnosed. So thank you so much. And I've reached the end of my presentation.
Yeah. Dr. Ashwita, would you like to ask some question? Do we have a question?
There is a blackout that has happened here. That is why I was asking you the time. So that's fine. I think if you need to ask any questions, you can please ask me. I'll put off my video.
Yeah. Well, actually, ma'am, most of it has been covered in your class quite well, the questions that were put up. So there's really nothing else to ask. It's all been covered.
Thank you.
Even the diagrams that have been asked about.
Yeah. So I hope I've covered all the diagrams that you need to draw in your exams and how you need to present your case. And if there is anything else?
Yeah, ma'am, from Viva point of view,
Yes.
could you just give a rough idea of from what are the important landmark studies that we need to really read up, revise before
Very
exam?
important. In all the Vivas, the first of all, to reach a point where they start asking you studies, the most commonly when you talk about steroids, the first thing that your examiner will ask you is, so what are the studies on steroids in relation to glaucoma? All right. And then if you talk about, ocular hypertension treatment study is commonly asked. The clinical studies on like tube versus trial, all these studies are not really asked. Then, so these are the common, studies that can be asked in your exams. Otherwise, it's good that if you reach that point, that is actually great. That means you will be going out with flying colors.
Okay, that's great. Okay, ma'am. With that, Dr. Ashwita, would you like to ask something?
Ma'am, is there any formula to calculate the target IOP or it's just based on the factors?
No, ma'am. There are target IOP formulas, multiple formulas actually.
Okay.
But they are difficult and tedious to use. Especially in clinical practice as well as in exam, right? So the important thing for you, everybody, not just me, for everybody to know is that target IOP you should decide based on the current status of the patient, whether it is early, moderate, or advanced glaucoma. Second of all, if there are additional risk factors like thin cornea, you have family history also present, you're diabetic also, then you have, obstructive sleep apnea, you have vasculitis and other things, ocular perfusion problems. So all these things, if they are adding on to it, you just decrease your target IOP slightly from what you are keeping it at.
Sure,
Right?
ma'am. Thank you.
With this, we'll come to the end of today's session. Thank you so much, ma'am, for such a well-articulated class on glaucoma. It was like an umbrella class which covered all the important high points for postgraduates before an exam. Thank you. We shall see you again, the viewers, on Friday, the 9th of May, for Approach to Long Case Retina by Dr. Devesh Kumawat. Thank you so much, ma'am.
Thank you.
Thank you,
Thank
ma'am.
you.